Hi, I'm Sunir Garg. I'm joined today by one of my favorite people in retina, my partner and service chief at Wills Eye Hospital, Carl Regillo. And Carl, today we're going to talk about the management of geographic atrophy.
Well, great. Thanks for having me, and I'm happy to talk about this exciting subject.
Yeah, we see so many patients with geographic atrophy every day, and one of the things that I still struggle with is who am I going to treat? I
Hmm.
have patients who come in who are asymptomatic, who have geographic atrophy, a disc and a half diameter away from the fovea, but they're scared. I have other patients who are somehow 20/40 holding on to three photoreceptors for their dear life. I have other people who are 2100 and their fovea is toast, and I don't have a great algorithm. How are you approaching this, and what tips do you have to help me have these conversations with my patients tomorrow?
Well, I'm going to take a step back before answering that by just stating where we are. Where we are is we're actually approaching 3 years since the first FDA-approved treatments for geographic atrophy are in our hands. Pegcetacoplan early in 2023, and a little later that same year, avacincaptad or ACP was also approved, both for GA of any type. Geographic atrophy is the label, and it's either dosed 4 to 8 week range, and that's based on how the drugs were tested in clinical trials. And the clinical trials, it's not easy to compare the two because they were slightly different patient populations, but the biggest difference being a little bit more restricted with ACP being just non-foveal GA, whereas pegcetacoplan enrolled patients that were both foveal and non-foveal. So why am I talking about this? Because, they didn't just treat all GA. There's a huge range of GA out there from, as you mentioned, small lesions far from the fovea, totally asymptomatic, to really large, central, really poor vision. Those types of patients were actually excluded from the trial. We don't know if these medicines help them at all. The trials were well designed because they honed in on the types of patients that we thought would be best suited to be treated. And frankly, in practice, I use both drugs. I've been using them since they were introduced, but I'm super selective and even more selective than the types of patients that were enrolled in those clinical trials. Why? Because, frankly, the efficacy is rather small for both drugs, comparably just a small decrease in the rate of growth of GA. That's what these drugs are doing. They're slowing the growth of geographic atrophy. And knowing that, your first inclination is, hey, we got to treat sooner rather than later. So we do want to treat lesions that are smaller, better vision, and so forth. It makes more sense because once the vision's poor, it doesn't make a lot of sense to necessarily use these drugs. Could still benefit some patients if the lesions aren't great, aren't large. But nonetheless, now I'll answer your question. With that background, these medicines work by slowing the growth, and they'll have a better effect in faster growing lesions. So, with all of what I've said, basically I'm honing in on earlier disease, faster growing lesions. And we've learned a lot based on these studies and older studies of how to identify at first encounter what lesions will probably grow fast and which lesions won't.
If I may kind of pick your brain a little bit on that. So, historically, at least leading up to these studies, the data that we had to look at progression was either hyperautofluorescence around the margins and
Mhm.
or rate of progression as we followed them over time. But as we've done these studies, we've also learned that certain lesion types progress quicker than others. So when you meet a person for the first time, new patient with geographic atrophy, are you then using what you're seeing that day to guide treatment starting that day? Or are you bringing them back like I used to 6 months later and seeing how they change during that time?
Yes, both. Um, in other words, if I have the luxury of patient-specific historical information, that's probably the best thing. If I've been following this patient for at least a year, I'll have a feel for whether they're average, fast, or slow growing. And obviously, I'll be more inclined to treat fast growing. I will not recommend treatment for slower growing or maybe even average growth, depending on a lot of other factors. And that's what makes this so challenging. There's a lot of factors that go into to answer your original question, who do we treat? We do know now that there are specific other features. That hyperautofluorescence at the border of a GA lesion on a fundus autofluorescent image, frankly, most have hyperautofluorescence. If they don't, and the minority don't, they're probably going to be slow growing. Those unifocal, no hyperautofluorescence are minimally growing at most. And I should also state that the growth rate varies enormously. So we want to identify the fast growers. And the fast growers, to answer that question, are more than just hyperautofluorescence at the border. Multifocality is an important one. So multifocal lesions grow faster than unifocal lesions. Larger lesions grow faster than smaller lesions. Non-subfoveal grow faster than foveal. So it's like it races to the fovea and then slows down. And there's more recent information out of the Oaks and Derby studies that show lesions that are further from the fovea grow faster. So you take all that into consideration. Now, the directionality of the growth growing towards the fovea, we can't predict that very easily. A lot of lesions, well, some lesions grow around the fovea and you have central vision preserved, and some don't. That we can't predict very well. So, for an individual patient, there's one other feature, by the way, reticular pseudodrusen. If you see that, and you see that very easily on a near infrared image of your OCT. That's going to be they're at high risk for faster growing GA and also higher risk for coronary vascularization. So it's not a good finding for sure for a patient.
And I think those are super helpful, kind of easy to remember points, which I also kind of do in my head is fuzzy math. Part of my other kind of math, if you would, that I do to try to figure out if it's worthwhile treating patients is their life expectancy. I mean, my impression with these drugs is unlike our anti-VEGF agents, where within a shot or two, patients are going to get better. This is more of a medium to long-term play. How do you factor in those kind of, how healthy the patient is, the treatment burden? Does that factor more into your decision with GA treatments than it would for your wet AMD patients?
Absolutely. Sure, GA is slower growing. You don't have to jump into making a decision to treat on the spot. Very much unlike wet AMD. Wet AMD, they're going to face irreversible vision loss over a very short time frame, months, certainly within a year, if not treated or not adequately treated. So regardless of age, that patient would benefit. It would prevent vision loss and, frankly, most of the time, improve vision. So whether you're 65 or 95, you're going to treat wet AMD. For GA, the story is a little different. In fact, you may be a little more aggressive as they're younger because they've got quite a long uh, potential life expectancy ahead of them. And if you get GA that's encroaching the fovea, they're going to be symptomatic and or lose vision to some degree within a 1.5 to 2 year time frame. And if that patient's 95 and has a lot of health problems and has a fellow eye that's good seeing, the relative risk benefit ratio may not be appropriate for that. It may not just be acceptable to consider treatment in such a patient.
And then so let's say, you talk to the patient, you agree, they agree that starting treatment's the way to go. Then how are you picking between agents? How often are you injecting patients? Are you starting off more frequently and then going to 8 weeks? Or are you doing 8 weeks from the get-go? Help me kind of figure that out because that's something that I still debate every day.
Well, to start with, once I've identified that patient that I think is an ideal candidate because they have faster growing lesions and they have vision to lose, and I want to slow that process. That's the goal here, slow or delay time to vision loss. Um, I'm going to start one eye first because often it's bilateral, right? I'll choose the eye that I think is most likely to benefit or in greater need. So actually, that's typically the better seeing eye. Um, and I'll start that eye first. It will be every 6 to 8 weeks on average. And the reason for that is in the clinical trials, there was not a lot of difference between 4 versus 8 weeks. A little better at 4 weeks, but that's very burdensome, and the risks are higher when I dose or have to inject every 4 weeks. What are those risks? Mainly, well, endophthalmitis is always a risk with an injection, so more injections is higher risk. but the risk of secondary choroidal neovascularization is higher with more frequent injections. And this is thought to be related to the PEG associated with both drugs, polyethylene glycol to make the drugs last longer. So doing it closer to every 8 weeks, you're going to reduce the risk of secondary choroidal neovascularization. Um, and even with avacincaptad in year two, where it was every 4 versus every weeks, was pretty much the same. So I lean towards every 8 weeks to balance burden, efficacy, and safety. And
Yeah,
so,
I
yeah.
do the same thing. I only have one patient who sort of is just so fearful of the whole thing that she wants to do whatever she can and wants to do every 4 weeks.
Yeah.
But the CNVM rates, it's interesting. It's half the number of shots, but the CNVM rate is meaningfully lower than half as much. So I do that too. The one difference, though, I guess, between our practice patterns is I'll start treating the worst eye first. Specifically with pegcetacoplan, there have been these cases of retinal vasculitis that seem to occur after the first exposure to the drug in that 1 in 4 or 5,000 rate. And I do then the worst eye first, maybe at a half dose with this taste test idea to see if they have an inflammatory reaction in the lower stick situation. Then perhaps I'll go to a full dose in that weaker eye. And then, assuming nothing happens, then I go kind of full dose on the fellow eye. So, can you tell me why you opt for the better eye first?
No, your strategy is actually very good and frankly very popular, and I've done that too, and will do that in many situations, um, especially if I choose to start with a pegcetacoplan, and it's because of that very rare but potentially devastating inflammation event that also is associated with retinal vasculitis and occlusions, and there's been some vision loss from such cases. Although we haven't heard as many recently, and there's a lot of potential reasons for that. It wasn't seen in the clinical trials, and there's some theories as to whether or not the population at large was sort of sensitized to the PEG molecule on the basis of COVID vaccinations. It's a long, complicated story, and we still don't know all the answers here. But that's a reasonable approach, and I've done it too, and I still will occasionally do it that way. Um, but it's important to recognize that both drugs, any drug we inject, can cause IOI, intraocular inflammation. Rates of IOI are a little higher with Syfovre, with pegcetacoplan versus ACP. And we have not seen the severe IOI with retinal vasculitis occlusions with ACP to date. And as you pointed out, uh, with pegcetacoplan, those severe sort of idiosyncratic reactions tend to be with first injection only. So it does make sense in certain circumstances. And if you're going to use pegcetacoplan, if you're super risk averse and really want to play it safe, to treat the quote worse eye. And like you said, it's like having a test dose.
And if I can ask you another kind of practical question, what do you do with the volume? Most patients do great with the full point one, but then I have some patients, particularly if they have some early glaucoma, where I sit them up and everything goes dark. And what are your strategies to mitigate that? And when it does happen, how often are you doing other interventions like a paracentesis or, a cotton swab decompression or techniques like that?
So actually, the viscosity of the drugs work in our favor to minimize acute, significant intraocular pressure elevation after injection. In fact, it's rarely a problem. If you inject slowly, um, and one you're forced to because they're viscous, particularly pegcetacoplan. But um, even as I recall, as an investigator in the clinical trials, it was specified you should inject over 5 seconds. Seems like eternity compared to injecting zero point zero 0.05 of a less viscous anti-VEGF drug. But if you inject super slowly, you'll get a lower acute rise in IOP, and it's less of a problem with patients graying out and so forth. If the patient does have moderately severe glaucoma, first of all, it may be a relative contraindication to use. And two, there are some strategies like I'll do a little ocular massage to lower the pressure and maybe inject even slower. We don't know if cutting the dose at all will also, that's going into uncharted territory because, lower doses haven't really been tested. and I don't want to shortchange efficacy. So those are the strategies. In that type of patient, if they have severe glaucoma, I'd be also more inclined to treat every other month and then more frequently too to minimize the cumulative IOP rises over time.
Sure. And then while we're on the topic of volume, I have some patients who I was treating with geographic atrophy drug, developed CNVM. I'm now treating that. Do you continue your complement inhibition therapy? And if so, are you doing both shots on the same eye in the same day? Or are you bringing them back, 1 month for one thing and the next month for the other thing?
Yeah, that's a great question because it's inevitable. If you treat enough over time, you're going to get some wet AMD. Um, So first, I tell patients the top priority is getting the wet AMD under control. So it's going to be anti-VEGF at first. Usually I just take a pause in the GA treatment just to get the wet AMD under control because it's going to be more frequent anyways, like monthly for a while. And then I'll do the usual treat and extend. And it kind of depends on how far I can extend that out and what the patient wants to do. If they'll have to juggle two different drugs, maybe on different days at different frequencies. If I can extend the anti-VEGF out to 12 months, that means they're going to have to come in between. And some patients will do that. I've treated some patients that have wet AMD that become GA in a given eye and vice versa. And so it's just a matter of coordinating. The specific question about whether I treat with both drugs at the same day. Let's say the wet AMD is perfectly managed every 8 weeks, and that's how I want to do the GA treatment. Um, I don't personally tend to do it the same day. It's perfectly reasonable and safe to do so. If you separate the two injections by at least 20, 25, 30 minutes is ideal and use the smaller volume anti-VEGF first. Um, Perfectly acceptable. We did that in the clinical trials. People do that in practice. I think there is the potential for reimbursement issues or some practical aspects of that nature. Plus, it's a little in a busy office. It may be hard to have a patient stay around for two injections over that time frame, but all of these are options and it's very patient specific, of course.
And then when you see patients follow up, I'm assuming you're getting OCT every time they come in, but mostly to look for CNVM. And then how often are you repeating autofluorescence or any other kind of imaging modalities on these folks?
Absolutely, OCT at every visit. And I don't necessarily do an exam every visit either. I'll do the exam after the first couple of injections looking for reactions, or I'll definitely do an exam if there's any symptoms of floaters, decreased vision, or anything unusual going on, any change. Um, OCT for sure, looking, as you said, for any wet AMD. I tend to do an exam maybe every other visit just to look for any new hemorrhage or anything else going on. And FAF, I'll often do it at baseline. I think it's a nice visual for patients. Honestly, I can get virtually all the information I need from the B scan of the OCT and the corresponding near infrared image. It tells me virtually everything. FAF to show the black spots is really useful for patients to understand, and I'll tend to repeat it mainly a year later, sometimes 6 months later, it depends, but it's really not for me. I can get everything I need in terms of wet AMD conversion and GA growth based on the OCT alone. So I actually get less and less FAF over time, but I'll do it mainly if I'm going to do it on an annual basis.
And I'll do something really similar. I'll get the fundus autofluorescence 12 months, 6 months. One of the questions that patients ask me that I just can't answer right now is, well, all this percent reduction you're quoting me, Dr. Garg, is great, but what's it doing for me?
Yeah.
And I show them the pictures and I'm like, well, presumably you've been worse had you not done it, but I can't tell you what your graph was like before and what your trajectory is now that we've treated. How are you navigating that and what are you looking forward to?
Yeah, the other type of question is it working or how well is it working? And I tell them, look, we really don't have good software or ways to measure growth easily and to look for that change in growth over time. I tell them both clinical trials, meaning the clinical trials of both approved drugs, both showed that it works across the board. It slows progression regardless of the lesion at baseline or ocular characteristics at baseline. Now, maybe more or less. Obviously, that's where we get into beta effects with faster growing lesions. But I tell them, look, we know it's going to work to some degree, and you've been shown to be or show characteristics of fast progression, so it's probably working even more so for you. You're better off staying on it versus not being treated. And that's the best I can do. But I'm sure in the very near future, there are going to be tools that will allow us to, one, predict growth at first encounter better than just us going through the checklist, as you mentioned, and looking at that growth rate over time. So patient-specific change.
Awesome. Yeah, I'm looking forward to that too. I think that'll be really helpful both for patient care, but also to help us better understand the disease and plan for future trials going forward.
Absolutely.
Cool. So believe it or not, our time is up for today, but I always learn a lot from you. I learned a lot from you when I was a fellow and as a colleague today, and I look forward to another conversation in the future.
Thank you. I learned a lot from you too.